Most of the high price seats are taken now.
All right. Well, good. Let's see. It is noon. Good afternoon, everybody. Thank you for joining us for the NNECTR Fall Seminar on Data Acquisition and Analysis with the Vermont Department of Health. My name is Liz Charnetsky. I'm a faculty scientist at Maine Health Institute for Research and one of the newer moderators for these seminar series. Before we kick off today, I will just briefly go over two housekeeping items that I'm sure we're familiar with living in a Zoom and hybrid world. The first is simply to stay on mute during the presentation. And the second is until we open up the question and answer portion of today's seminar, please post any questions that you might have to the chat, and we will be working on monitoring the chat as questions come in there. And with that, I am pleased to now introduce our speaker, Jessie Hammond. Jessie Hammond is the Director of the Division of Health Statistics and Informatics at the Department of Health in Vermont. She was born and raised in Vermont and has been with the department since 2002, first as a data analyst and then as the head of public health statistics section, before transitioning into her current role, which is leading the division. After obtaining her Master of Public Health and Epidemiology from Emory University, and before returning home to Vermont, she spent 2 years working for New York City's Department of Health and their tuberculosis control program. So thank you again, Jessie, for joining us today, and I will turn the floor to you.
Great, thank you, and thanks for asking us to share with you today. Hopefully it's all information you're interested in. I've seen a few friendly or new or familiar faces, I should say, in the chat. So I'm happy to see you all here too. So I will go ahead and share my screen. Hopefully. Okay. And this is a little bit awkward for me, but because I'm using my bigger screen, which is not the screen my camera is on, but I will do my best. As Liz so nicely said, I'm going to talk with you about data acquisition and analysis and what we do at the Department of Health. My colleague, Amanda Jones, is lurking. She and I work pretty closely together, and she's here to jump in if I go awry, but also to answer some questions, because there are a couple of sections that are a little bit more specific to her, so I may rely on her as needed. Okay. So I work with the Division of Health Statistics and Informatics, and what our role is to track health data and trends and assess the health of Vermonters. So essentially, to do that, what we do is we plan things, we plan projects, we work very closely with our program partners and other parts of the department, and we collect a lot of data, we analyze a lot of data, we produce reports, we consult with others, and we also perform evaluation activities, so program evaluation. And how we collect data, that comes in various methods, but one of the primary ways I'll talk about today is through some of our health data registries. And then we have a lot of data systems, and those require a lot of maintenance and development. Now, I wouldn't say we necessarily do that maintenance ourselves. In some cases, maybe, but we work really closely with our IT partners at the Agency of Digital Services to maintain those systems. So generally, what our overall objectives are, or the work we do, is to support timely, quality, and accessible data collection, analysis, and evaluation methods. We try really hard to ensure that our data systems are modern and certainly secure, and that we continuously work to improve them, and that we use the data. We don't want to just collect it, we want to use it. So we use data to inform and improve public health programs and policy. So today, just the objectives I wanted to accomplish are, I want to provide you some information about the types of data that the health department collects and how we receive that information. And I'll give a high-level overview along with a few examples with some more detailed information. I also want to share some of our data modernization activities, because that's a really strong point of emphasis for us right now. And then give a brief overview of the data analysis and what that looks like at the department, how we use information. And then, and this is where Amanda will most certainly come in, most likely, is share information about AI with the Vermont state government, both now and kind of looking forward. So first, data collection. The data we collect, and this list is very specific to my division, and then I'll speak a little bit to data collected in other areas of the department. So we collect data from our immunization registry, our cancer registry, infectious disease. So we have a data system where cases are reported, and then we also have syndromic surveillance, which is a very timely system and uses ER data, prescription monitoring system, vital records, which this always happens when I present, I forget to use my notes. So let me collect here, or move my notes forward. So vital events, births, obviously, deaths, but also marriages, divorces, civil unions, dissolution of civil unions, abortions, and fetal deaths. So we collect a lot of information from vital events. Violent death reporting system. So any kind of suicide, homicide, also there's a section within that system for overdose deaths. I believe undetermined deaths are also in there as well. And so that system pulls information from a lot of different sources, but really helps inform and understand that type of death. Our birth information network, which is, I couldn't tell you all of them, but information related to congenital birth defects. Largely, our healthcare workforce census data, which I think is a really interesting and probably underutilized data source. And recently we launched an ALS registry, and then we have various population-based surveys, which are things like our youth behavior risk surveillance system, an adult version of that survey called the behavioral risk factor surveillance system, a pregnancy risk assessment monitoring system, which are all done with federal funds. And then we also have a household health insurance survey, which is done with state funds and only done periodically, as well as an adult tobacco survey that's done periodically. As I mentioned, I was talking mostly about data and systems within my division, but there's data collected elsewhere across the department that my division may or may not use. There's EMS encounter data, women, infant, and children programmatic data, You First, which is breast and cervical cancer screening programs, newborn screening, hearing screening, and developmental screening, as well as lead screening. You'll hear a little bit more about those four later because they because they tie with the vital records and immunization system. So I'm going to speak about that coexisting system that includes data from all five. And then there's other programmatic data. There's programmatic data related to substance use, there's programmatic data related to tobacco programs. There's also data within our environmental health division. I'm specifically thinking of our environmental public health tracking program, which doesn't necessarily collate or collect the data, but it uses the data from multiple systems, but through an environmental health lens. And the health department also uses data from external sources. Two examples, both of which happen to be owned by the Green Mountain Care Board, are VCures, which is our all-payer insurance claims data system, as well as our unified health, our hospital discharge data system, which is primarily based off of billing information from hospital stays. So how we receive data? We receive data in a lot of different ways, manually. So sometimes things are phoned into us, mailed to us, faxed to us. We're trying to get away from these, except for in the case of some of our population-based surveys. So still may utilize a mail or phone. But we really want to get an infectious disease as an example away from manual reporting. We received data electronically. So HL7, our immunization data, as well as some of our infectious disease data comes through HL7. We are also working on implementing FHIR data, or FHIR messaging. And the first data system we will be launching that with is vital records. We have secure electronic forms where the provider may submit something by filling out a form that comes directly to us, and then batch file upload. There may also be direct entry into a system. As an example, nurses in a provider office. If the provider office is small, committing to HL7 messaging may not be something that is of particular value to them, and they are able to access a registry directly and enter the information directly. Information is sometimes self-reported, as an example, with those population-based surveys. I'm filling it out for myself and reporting my experience. And then we also utilize health records. So we work closely with the Vermont Health Information, Vermont Health Information Exchange, the HIE. We receive laboratory reports electronically. We receive, and manually. We receive case reports. And then we also have immunization health records and prescription health records. So now I'm going to shift a little bit to giving some of the examples, a little bit more detail about each of them. So as I mentioned, we have population-based surveys. Each survey has a different methodology, but generally speaking, they collect a representative sample, and then that information is usually weighted to represent the whole population. I would just say for our one survey that we do differently than most other states is the youth risk behavior survey. Instead of doing a sample of schools, we sample all schools. So it really is, we collect a lot of information from students every other year for that survey. And it's a really rich data source. But in terms of methodology, some of them are telephone based, some of them have mixed mode, so utilize paper and phone follow-up, and then some are paper / computer based. They used to be paper, are now computer based. The information is self-reported on those surveys, as I mentioned, but the data is varied. It collects information on behaviors, both preventative and risk behaviors, prevalence of disease, insurance status, which is really important information, and a lot of times engagement with healthcare and experience with healthcare. The healthcare workforce census, as I mentioned, I personally think this is an underutilized source, and it collects data on more than 20 healthcare professions, and it's tied to relicensure. So every 2 years, when a provider in any of these professions submits their relicensure, goes through their relicensure process, they are asked to complete the survey. And it collects information from all providers and a response rate of 99%. So again, a very rich source of information. It collects demographic information about the individual, where they practice, the specialty, the type of practice, number of hours per week, intentions with regard to practice. So, are they intending to retire? And so in a state with an older workforce, that's a really valuable piece of information for planning. And it also allows the calculation of full-time equivalency, or FTEs, of providers by specialty and geographic region, which again is valuable information, as particularly in a rural state where there are gaps in service and gaps in coverage. As I mentioned before, we have an integrated data repository that includes 5 different data systems, and we call it Sphinx. I couldn't tell you what Sphinx stands for. I do believe the P is public and the H is health, and the I must be integrated, but I am not sure what the S and an X are. But Sphinx is an integrated data system. It includes vital records, immunizations, hearing screening, developmental screening, and lead screening. Whenever an individual is born in Vermont, a record for that individual is created. And then immunizations can be used to create a record as well. If for some reason the birth isn't registered right away, sometimes data entry can take a bit, or the birth might happen at home, and it may take a slightly longer amount of time. If the child gets immunized right away, that can create the record. Or obviously not everyone that lives in Vermont was born here. An immunization can also create a record if you move here and then get an immunization. This is a little bit of an older system, but we work continuously to try to keep it up to date. And it works really well and is a valuable tool for the department. As I mentioned, vital records, I just want to call that system out separately. So all births and deaths occurring in Vermont are required to be registered in Vermont. We also do have interjurisdictional exchange. And through that process, we receive reports of births and deaths of Vermont residents that occur in other states. This is really important in Vermont because, as you might assume, know that a lot of care is received at Dartmouth. It's important that we receive that information from New Hampshire. But care also happens in Massachusetts and New York as well. So we receive that information. And then deaths also don't always happen in the borders of Vermont. And so we receive those records from across the country as well. We report the birth and death information electronically to the National Center of Health Statistics. There is some manual effort in this process currently, in that we have to upload files. But I mentioned earlier that we're working on fire messaging, and so that process will happen automatically once that is implemented. For births, the system used for registration is the electronic birth registration system, and that process is implemented by hospital staff and vital records staff. Home births are entered by the records team. And then there is also a process for unattended births. Because you don't always have a medical provider when you have a child. And then, as you might imagine, the death registration system is the electronic death registration system. And that information is entered by funeral directors, the medical examiner's office, medical providers, as well as vital records staff. The other thing I just wanted to mention is that birth and death records in Vermont are public records and can be requested, but certified copies of those records are restricted access. Immunizations are required to be reported to the Vermont Department of Health by state statute, and we receive that information in 3 different methods. HL7 is sent. It's the majority of immunizations, are sent by HL7, and our process goes through the Vermont Health Information Exchange. So the provider's office is connected to the HIE, who is then connected to the health department, and information flows that way. Providers can also direct entry into the registry, and then we also allow for bulk file upload directly into the registry. Those files are provided directly to the health department. HL7 messages are imported nightly, and then direct entry, those are live as soon as you push save, and then uploads occur at specific timelines. There's a minimum number of records that have to be included in a file before it can be uploaded. So depending on the size of the provider, that might be biweekly or monthly. For the immunization registry, we also have interjurisdictional exchange, though I would say this is more limited than it is with vital records. A primary agency we exchange with is New York State, and as well as New Hampshire, though with New Hampshire, that's a bit more limited, but we are working to improve this. Sharing of record level immunization data beyond the registry is limited by statute, but there are processes for requesting that information. And the immunization registry and the Sphinx system as a whole was developed by I say the Department of Health, but really it was our IT partners in collaboration with us. But a big win, we've had a lot of immunization modernization activities lately. We recently implemented bidirectional exchange, which means that providers who have signed on and been brought on board can directly request from their EHR someone's immunization information. So they no longer have to look up someone's information in the registry and then pull it in. They can push a button and the information comes to them. So that was a huge win for us. The cancer registry, cancer diagnoses are also required to be reported to the state of Vermont by statute. We receive information both electronically and manually, but we are shifting to all electronic reporting. And in this case, electronic reporting is more in the avenue of file uploads. We do have some HL7 messaging, but that's not the primary method of receipt currently. Again, we participate in interjurisdictional exchange. This happens twice a year. And we perform linkage with other systems periodically to ensure that all diagnoses are reported. One of those is our U-First program, but also we do this with the mammography program at UVM. And then again, sharing of record level information is limited, but possible. Infectious disease, we receive these reports through multiple methods, as I mentioned, manual, paper, fax, telephone, online forms. Increasingly, we have electronic laboratory reporting and electronic case reporting. Electronic reports are transmitted to the Department of Health in multiple methods. HL7 connection directly to the Department of Health. So currently this is hospitals and some labs. And then also through HL7 connection to the HIE, which is also laboratories. And then there's HL7 connection to the American Public Health Laboratories, or APHL, who has a connection to BDH. And they are able to send both ELRs and electronic case reports. That's a lot of different types of connections, and we are working to streamline that and are starting to put some plans in place for that. So it's exciting time there. And again, we participate in interjurisdictional exchange. The little squiggly mark on this is a little bit off, but I did want to note that de-identified information from our infectious disease system is reported to the CDC for nationally notifiable conditions. This is obvious. This would be is a very high priority area for modernization, having just come through an infectious disease related pandemic. So a lot of attention is in this area currently. Syndromic surveillance, which is the system we have is called Essence, if anyone has heard of that. But it's data from emergency department visits, and it's used to detect unusual patterns to help determine whether a response is needed, and it can serve as an early warning system for public health. This was initially created and used for infectious disease, but that has expanded over time. We now use it related to suicide. We use it for overdose detection, and then heat and cold events. So we're really trying to use it creatively and increasingly. The prescription monitoring system. So prescriptions that are scheduled 2 through 4 dispensed at Vermont licensed pharmacies, are required to be reported to the Department of Health. And since I didn't know this, I'll just say that scheduled 2 through 4 prescriptions includes classes such as opioids, benzodiazepines, and medications for opioid use disorder, stimulants, and others such as hypnotic sedatives. So just for clarification there. Again, we participate in interjurisdictional exchange, so a lot of sharing across states. And this system can integrate with electronic health records through various methods. So those are just some of the examples. I'm happy during the question and answer period to try to speak to some of the other sources as well. But I also, before moving on, wanted to touch on some of the non-VDH sources. Our ability to access these often requires a data sharing agreement or an MOU, depending on who that is, who the owner is. And in some cases, access is provided on an ongoing basis, and others is just for a specific project. So VCures, which is the All Claims Payer Database, we do have access to extracts on an ongoing basis. But we also have, well, they have a very rigorous data governance process that we participate in. And there are often requests or projects where people would like to link the All Claims database with data from the Department of Health. For example, and some of these originate at the health department, some of them don't. Some of those projects are linking vital events, so linking deaths most often. But also we have had a request for linking cancer registry data with VCure's data. And so that permission has to be granted by the owners of both systems. And then we also have created an overdose social autopsy and most recently a suicide social autopsy, which links data for deaths from each of those outcomes with data from various sources, both within state government and outside state government. And so that's required a lot of data sharing agreements. But we seem to have a pretty smooth process now, knock on wood, and they've been really valuable projects for us. So data modernization, I've referenced it a couple of times, but to go into that a little bit more, I don't think it's any secret that the COVID pandemic pointed out some weaknesses in the public health data infrastructure. Both generally, not just specific to Vermont, but also in Vermont as well. And the CDC has put forward a North Star architecture as their vision for modernizing public health data systems. I'm not sure that I know that I couldn't explain that in great detail right now, but it is something we reference and are striving towards. It does have a focus on infectious disease and vital records. But we have also included other systems in our data modernization vision. And so we have also included immunization, and immunization registry was a very widely used and valuable data source in the pandemic. And so we have expanded to include that type of system in our vision as well. So our areas of focus include reducing manual reporting of events, increasing interoperability between systems. We want to address our aging systems. We want to create data warehouses and data lakes. Spaces to enable analysis. And we want to collaborate with our health information exchange, which I'm going to talk a little bit more on the next slide, I think. But they were a valuable partner for us in COVID, and we want to continue to leverage that. So yes, as I said, the Health Information Exchange was a key partner in the pandemic, but is an ongoing key partner with the Immunization Registry. And during the pandemic, the value of the HIE to public health was really highlighted in terms of onboarding for electronic laboratory reporting. We were able to use information, demographic information, and other information from the HIE. We were able to look it up and use that to complete records. And prior to the pandemic, and continue to do, we provide them death records so that providers have ready access to that information, because when someone dies, not all their providers necessarily are notified. And since the pandemic, the Department of Health's use of the HIE data to support programs has drastically increased. Examples of that are, we use it for clinical information to support quick visits. We use it to supplement information in the violent death reporting system. And then we have various case management programs where information in the HIE can be used as a frontline source and trying to reduce the number of calls we may have to make to providers to obtain information. So trying to streamline the systems and reduce the burden on providers. Using some funding from a grant, we are developing an integration strategy with the HIE. With that really focusing on what are the systems we want to integrate, and then what are the steps to achieve that. We really stressed in this project that it can't just be, you should do this, really telling us how, in what order, and because to help us make sure that we're able to get there. So that strategy should be ready in the next couple of months. And so we're really excited to see that. I'm going to shift topics now to data analysis. So first, just the tools and the use. So most of the time, currently, we complete analyses using data extracts from a system or directly accessing information in a data warehouse. The primary tools we use are SAS, Sudan, SPSS, R, Python, and SQL. And our analysts have access to most data sources at the department, but some specialize in specific data sets. But we have processes to request information and share data with each other. And linking data is increasingly of interest. And I just want to highlight that data governance is really the key to linking data. And I know there are people on this call who've been frustrated with the health department, that it can take a long time to work out those processes. But we do eventually get there, and the outcome is both rewarding and generally and worth the time to do that. Statutory barriers can exist at times with linking data, but we're increasingly working to resolve those if it serves public health value. So I also really wanted to stress, because this is part of our modernization effort as well, is a lot of things I talked about on the prior slide are still somewhat manual processes, but we're really working to change that. So we are increasing the use of our dashboards, and I'll show you a couple of examples of those afterward in a minute, but so that people can look at information, and information is updated regularly and made available to the public more frequently. We are training staff to support automation. We implemented a pretty significant training effort to upskill some of our staff in the past year, and we're looking to continue that in the coming year. And we're looking across our systems and leveraging new staff to identify automation opportunities, because we need to reduce the burden on the people doing the analysis with all those early steps so that they can focus on the complex and interesting work. And we want to put more capabilities in the hands of our analysts, and by that I mean taking it out of the hands of our IT staff and moving it into the hands of the analysts, allowing them to schedule tasks, as an example, so that we can own a project from the beginning to the end. And that requires trust and collaboration on the part of IT. And so we work really hard at that relationship. And again, many analyses combine data from multiple sources. So moving from just the analysis to how we use it, there's lots of things on here, but we want to evaluate programs. We want to make sure we're spending money wisely and making a difference. We have a lot of requests to respond to. That's one frequent thing that we are having to do from lots of different sources. We want to support policies, understand health, understand coverage, identify trends, quality improvement, all of those types of things. And then now I'm just shifting a little bit into some examples. Data analysis can be very specific. So we have reports like this that are about the burden of uncontrolled asthma in Medicaid recipients. So like a very narrow topic, and this is tied to some programming. So they can be this very detailed, or they can be much more comprehensive. So this report, which is about heart disease and diabetes surveillance, is a long report, but it has data from many different sources, and it looks at a wide scope of topics related to this. So this gives you like a really drilled in, detailed look at heart disease and diabetes in Vermont and the experience of those with those conditions. As I mentioned, data dashboards are becoming a common way to share analyses. I'm a little bit scared to try to click on this and show you, but I guess I'm just going to leave it because I don't want to blow up the sharing of the PowerPoint. But this is our this year's iteration of our COVID-19 and flu vaccination data dashboard. And it has tabs for COVID-19 vaccination, flu vaccination, and then for those that received COVID-19 and flu vaccines on the same day. And so it gives an overall view, so who has received the vaccine this year. And then it has breakdowns by various demographic categories, and you can look at various geographic breakdowns. The bad news is, I guess, not as many people are getting the COVID vaccine, but the good news is we can look at it and understand where the gaps are and where we might reallocate resources. I had talked before and just wanted to highlight, this is another new dashboard that's been released recently by one of our staff, looking at suicide surveillance. And this dashboard, helps to address a lot of the ongoing questions that we may get. So she's able to spend her time working on other projects rather than answering those requests. So this particular page is the death portion of related to suicide. But then there's also emergency department visit and MAPS information, and this is updated monthly. So this is one we're really excited about. And you can also limit the population. And then we also have, from just death information, this is the link to the social autopsy report I mentioned previously that looks at data from across a multitude of sources. And we do a monthly report of fatal opioid overdoses. Just to highlight a couple of other things, because I thought people might be interested in cancer incidence rates. We release those rates annually, usually in the late spring, I believe. And I wouldn't necessarily say these change drastically each year, but they are interesting to look at. And then circling back to healthcare workforce, this is just a snippet from one of the pages in that, and excuse me, in to be honest, I can't remember which one I pulled this from, but I just wanted to show that it shows where the FTEs of service are, and where there are limitations in coverage and in service, but it also breaks down into what percentage of the type of provider is accepting patients or full-time, and then looks at trends and FTEs for each of them. All right, and shifting lastly to AI, is Amanda, who is here. She'll be able to answer questions on this topic, but the state, she's our department's representative to the board, I guess, the state board. So we have two bodies working on AI in Vermont, related to oversight and enablement. Our Agency of Digital Services has an AI division, and then that operationalizes the ADS guidance and provides an AI Center for Enablement for the state of Vermont. And then this is the group that Amanda sits on. There's a council for artificial intelligence that meets regularly and shares their perspectives to make sure we're all in alignment. There has been a code of ethics drafted, and now they are working on statewide recommendations and appropriate uses policy. I would say in our department, a lot of the areas we've talked about using it or staff have started to use it are related to working on our code for data analysis, solving problems, kind of that automation, troubleshooting and automation. And in some ways, I would say helping with writing. So not doing the writing, but like if you're so you're struggling with something, it can be helpful in that way. Oh, I forgot about this slide. So yes, AI is really emerging in public health. We have taken trainings and attended webinars. And as I said, it's mostly being used assistance with code, but it always requires human review per the code of ethics. And I think as people get more comfortable with it, both when there's the appropriate uses, but just general comfort with AI, we'll see use grow. And areas of growth might be in predictive modeling, machine learning, or anomaly detection. And that felt like it took 6 years to me, but apparently it only took about 45 minutes. So I'm happy to answer questions or talk about things further. But I'll stop sharing just so I can see you all. Oh goodness, there's 24 things in the chat. Okay.
Chat is mostly folks introducing themselves and telling us where they're at. So. B. Harder has their hand up, and then Gary.
Okay. Hi, Valerie.
Hi, great talk, Jesse. Thank you so much. I had a quick question about the Sphinx ID. I saw that it includes, I think, 5 data sources are linked with this unique identifier. Are there plans at the health department to use the same Sphinx ID across other data sources?
Not currently, no. I don't know what that would involve or what that would require. We certainly could talk about it, but I am not aware of any plans to do that currently.
Gary, would you like to go next?
Sure, I'll give it a try. Okay. I mean, there's an increasing appreciation for the value of the data that the Department of Health creates. Could you give us an overview of how, in fact, does one request data? What is the process? Is there a central portal, a portal that you request it through, or do you have to go in and identify the particular type of data and request it through specific areas of the health department?
That's a good question. Currently, I would say each data source typically has a contact identified, and you should reach out to them directly, and they will tell you what the specific process is for their data system. But I'll also follow that up with we are working on strengthening our data governance framework. And so an output of that may be a centralized request portal. You can also send an email to, we do have a centralized data request email, which I can put in the chat when we're finished. You can always submit a request there and we will triage it to the right program.
I have 2 more questions for full credit on the exam. The first is when data is secured from the Department of Health, are there restrictions on utilizing it for publications? And secondly, when in fact it is able to be incorporated into publications that go out to the biomedical research community and the general public, how does one cite the data?
Also a good question. If the information you request is part of the public record, once you receive the file, there's not a restriction on publication. And also generally, if you receive information through a data use agreement, there's usually a statement in there related to publication. I wouldn't say it's a restriction other than it has to be aggregate. And I think we generally ask to be notified when it's submitted for publication for awareness purposes, but it's not generally, I wouldn't call that a restriction.
Thank you.
Yep. And did I miss any part of the question? Sorry.
No, you got full credit.
Okay.
Jesse, there's a question in the chat that says, I see you're collecting violence-related data, presumably to reporting to NVDRS. I have a specific interest in firearm-related injury and death, so I'm wondering what type of data you have focused on firearm-related injuries and how much can be shared.
Yes, you are correct. We're reporting that it's part of the National Violent Death Reporting System. You can request information from NVDRS directly. They would be able to give you a data file, assuming that's approved. Our violent death reporting system is relatively new, and by new I mean young. We don't have many years of data in it, so I wouldn't say we have necessarily explored sharing a data file from that independently of the VDRS National Violent Death Reporting System. But I'm certainly happy to talk about that further because it certainly includes firearm death information. In addition to that, or part of that, certainly our death certificate system has information on firearms. We have collected information from those population-based surveys related to firearm storage. So not necessarily the outcome, but the preventive activity. So I don't think I answered your question particularly well, but we do have information, and I guess I'm happy to talk about it further to talk about what could be shared.
No, that was perfect. Thank you very much. I actually have some data from NVDRS that I requested, but it's interesting that on the federal level, as well as what we find on the state level, is that for every one person who dies from a firearm injury, 2 survive, and we don't have any information on the 2 that survive. That actually seems to be the biggest hole in terms of data that's received. So just trying to explore what's actually out there.
That is interesting. I'm trying to think of there might be something from if someone is hospitalized, there may be something in there if that's related. So in the hospital discharge data file, there may be something in that data system. And there is a public use file for that you can access or request from our website. I would say the all-payer claims, but that doesn't include anyone who's uninsured. And so that is possibly a gap in that population. I'm happy to kick it around with people at the health department. I'm not always very good at coming up with things on the fly, to see if they have other thoughts on.
And it's okay. I don't mean to take up too much of your time with a very specific request.
No, those are the interesting things to talk about.
Hi, my name is Richard. I'm a third-year medical student at the Larner College of Medicine. So earlier you had mentioned some of the population-based surveys you distribute assess pregnancy risk assessments. Could you speak to what types of data are collected in that survey? Is it talking about like access to healthcare or transportation, or some of the information, some of the data comes with that?
Sure. I won't be able to come up with everything. Certainly access to care, what care they've received during their pregnancy. There are questions about risk behaviors or substance use during pregnancy. I believe there are questions related to, it's a pretty sensitive survey. I believe there are also questions related to domestic violence in the home around pregnancy, breastfeeding, and how intentions related to childcare. There are questions about return to work and intentions to return to work, certainly insurance related questions. So it's a pretty wide scope of questions.
And is that given on online, or is it distributed through the mail, or how are
that survey is distributed through the mail initially and then follow up by phone. So we employ two staff who two staff who share one full-time position, and they make those calls to mothers for follow-up.
And is this divided by region / county as well?
I believe we can look at county. I don't know if we can do that on an individual year basis or multiple years. Would have to be off the top of my head. I can't recall, but we do have a relatively small number of births. So it may take multiple years to be able to look at that level.
Thank you.
Mm-hmm.
I don't see any other questions in the chat or any other hands, but if anyone has another question, please feel free to go ahead and speak up. Oops. All right. Well, thank you everyone for joining us this afternoon. I see that Sheila dropped some information in the chat about our next series. It's entitled Mental Health in 2023, Risks and Opportunities, and it's going to be held on December 15th at this time. So we look forward to seeing you there. Thank you, everyone.
Thank you very much. Thank you,
Jesse. Appreciate it.
Yeah, thank you. I'll put that email address for data requests in the chat before I sign out.
Wonderful.
Thank you.
Thank you.